Okay, this is going to be the affective domain for an EMS IC class that we're teaching through the summer of 2020. The affective domain we've talked about at least a little bit already when we were talking about the adult learner, and then when we just were covering domains, we talked about the cognitive, the psychomotor, and the affective. And at that time, we would have talked about things that we look at as far as characters and EMS students and paramedics. And then also, maybe you'd say more importantly, as an EMS IC student, what the Bloom's taxonomy levels were. So when we're talking about the affective domain, it is one of those things that people, I would say, least like to talk about. And it is also where you least like to spend time when you're in class because you're just talking about attitudes, beliefs, and behaviors. An important point to start with is that at the state level, and I would say at the federal level, at COAMPS level or KHEP level or NHTSA level, um, the affective domain has to be there as far as evaluated, and programs have to have the ability to fail somebody because of their affect. So I think that's why it is one of those things that are difficult to talk to, difficult to bring up. To do affective evaluations well, you have to do them often. And again, at the end of every course, you have to at least have one affective evaluation, and the student has to pass that. So um, to me, when we're talking about affective, there's two basically distinct different discussions. One is the evaluation of character, all right? You're going to be looking at things like a student's ability to show empathy, their timeliness, their self-motivation, their ability to time management stuff, their leadership, ability to communicate, all of those things. And then the other side, and again, what I would think is probably more important, is the Bloom's taxonomy. The idea that every skill that we teach, every piece of information, there's an affective component to that. And that is the student receiving, responding, and valuing the information that you're giving them? So we have, the first thing when we talk about evaluation, we have to talk about teaching, right? And how do we teach the affective in the affective domain? And really, this is a constant thing. We're always teaching in the affective domain, and the way we do that is modeling behaviors. So we should understand that our students will model the behaviors that we are showing. We also have to have some discussion. We can talk about it a little bit in lecture, and then the evaluation component itself is part of the education. So the one thing that we as instructors, it's pretty easy to understand, maybe as EMS instructors, easier than other instruction, is we're responsible for putting out professional EMTs, all right? They have to develop a professional judgment. That if we just teach them how to start an IV, all right, just teach them the skill, that is not very valuable, all right? We have to teach them all of the didactic information around the skill of starting an IV. What patient would we start an IV on? And then why are we starting an IV? What is it going to be helpful for? What situations might we not start an IV? All of that didactic information. But then for the affective part, we also have to get them to understand and be able to prioritize when they would start an IV. There's very, very few things in EMS that we can just say, you always do this or you never do that. So there are some things, but like we always use the aseptic technique during starting in an IV. But you couldn't really say we always start IVs on patients with respiratory distress, all right? Because there's going to be some things where maybe we don't. Maybe if that respiratory distress is a priority 1 patient who is actually less than 1 minute from the ER, maybe we would start scooting with that patient and get him to the ER without starting an IV. So the affective domain is how we're going to help the student get the right attitude towards starting an IV, all right? And that is not just starting an IV, it's attitude towards being able to communicate with first responders and be able to communicate with an RN at the hospital, communicate with family, communicate with patients, communicate with everybody, how important time management is, all of the components, everything that you can think of that has to do with EMS education, there's an attitude that goes towards that too. And that is something that we have to teach and then evaluate also. Here is pictures this is a long time ago that I've put this together, but this is from Europe, I believe, somewhere. And this is an EMT or paramedic who is taking care of patients. And it really goes towards the argument, I guess, or the discussion that ability determines capability. All right. So what is your ability in starting an IV? What is your ability in being a patient advocate? What is your ability? All right. If you are able to do it, you are trained, you know the didactic information, you know what material you'll need to have, you have the skill because you've practiced it. All of that ability determines capability, which is mostly learning, practice. But then attitude determines performance. Are you actually going to do it? So if you have a student like this person here who posted herself while taking care of a patient, again, this is somewhere in Europe, by that red, blue, and white flag, that's either a French or a Dutch flag, I would guess. So this patient was not treated appropriately. If you have that sort of attitude, it's less likely they're going to be doing the things for this patient that you would want them to do in a way that we taught them when we were teaching them in the classroom. And so what characteristics do we need to see in our students? And take a moment to think about that. What characteristics? We could actually list all of these out and then start throwing them on a whiteboard and say, which one's most important? What one's least important? So take just a moment and think about that. What characteristics do we really need? It doesn't say want. What ones do we need to see in our students? And if we cannot get our students to show these characteristics, then what are we going to do about it? And so some of these characteristics are kindness, honesty, compassion. They have to be knowledgeable, and for them to be knowledgeable, then they're going to have to listen to you in a classroom. They're going to have to retain that information. They're going to have to regurgitate that information on tests. So all of those things are very often words that are brought up when we're asked, like, what characteristics are we going to want to see in our students? So other things that we want to see them doing is we want to see them have an appreciation for a patient's pain level, all right? And then be a patient advocate and ask for a morphine order. So here you can see this as we can have a patient who has a lot of pain in the classroom. It could be a minimal looking injury, but a pain scale 1 to 10 is a 10 or a 12 and crying. And how does your student take care of that patient? We can respect the patient's modesty and cover them up with a sheet, and we can do that with our mannequins, all right? How quickly does the patient get covered up when they're kind of used to seeing mannequins in different dress. Some of them are naked, sitting on tables all of the time. He set up this scenario as this is a patient who is naked. what are you going to do? And see if they do that, and then have a talk about modesty. And then defending or respecting a patient's right to refuse care. All right, how does the student deal with that patient who really should go to the hospital after, with a complaint of chest pain, after maybe waking them up from a diabetes call or a low blood sugar call, post seizure, all of those. How do they communicate with the patient? And so when we are talking about all of these things, we as instructors have to model the behavior that we want them to model. And we should then be able to trust this patient that outside of the purview of instructors, they would continue to have this good ethical care. And so what are the levels for Bloom's taxonomy? And we see there's our acronym there is COVRR. By this time in class, you should be able to remember cover and then be able to write out our Bloom's taxonomy. And so here we see at the very bottom is receiving. You might not be able to see the whole word, but hopefully you know that. Receiving is the first thing. And so when the student is receiving, they are just simply listening to you, all right? Some students aren't at the receiving level. If they don't like you, it could be something's happening in their personal lives. It could be something maybe between you and the student. Could be the topic that you're talking about where a student may not be receiving at all. They're stressed out because of something else. They're just not receiving. They're bored in the classroom. They think they know it all already. All of those kind of attitudes would cause a student not to receive information. All right. It could be your reputation. It could be something with you. It could be the way that you're presenting this information. It could be something in your history. All right. The next is responding. All right. And just to go a little bit more with receiving, you have to own that. And we've talked about that before as far as starting out with motivational stuff at the beginning of our presentations. That's going to get the patient, I'm going to continue to say patient, I think, instead of student for the duration of this presentation, but you need to get the student motivated to listen to you. So responding is now, not only are they receiving and listening to you, they're able to say stuff back to you, all right? They're having a conversation with you. If you're having them do a skill, they're doing the skill, all right? If you're telling them that this is an aseptic technique and you have to put in, use an alcohol prep to slide across the top of a vial, they do that. You might say every time at the responding, it doesn't really have to be every time, but they're consistently doing that. They understand it and they're doing it. They might forget every once in a while at the responding level. When we're at the valuing level, and this is the level that we need all of our students to be at, all right? They have to value that information. They value it, they're responding with it, and then if they value it, they will do that without you watching, all right? And here, this is thought of as a conscious compliance, all right? It's conscious compliance still. Beyond this, we might get to unconscious compliance, but here we're still at a conscious compliance at the beginning anyways of valuing. They comply with this because they know it's the right thing to do. All right, so they will be using gloves, wearing a mask, whatever it would be. They are following that behavior, and they do that without being told to do that, without reminders. It's part of their nature to use aseptic technique to splint people who have a possible fracture, to bandage or to clean and then bandage wounds, all of those kind of things. They value the information, so they're following through on the behavior. Organize is beyond where we really need initial students to be. But as a continuing ed organization, you might have the need to have all of your people at the organized level. And here they have to have some experience. That's why we kind of throw it out as above what we have for an initial education. But some stuff, they'll be at the organized level. They'll have gained the experience through the clinical component and through repetition and simulations. So now they get it. They valued it. They're doing it all of the time. But when you're organizing it, now you're actually able to prioritize where and when you would do it. So let's go with starting an IV. As a student, I value starting an IV early and often for a chest pain patient, so we'll do that. Maybe try to do it on scene, get it done, be able to give drugs earlier, be ready for a cardiac arrest, all the different reasons and rationale that you'd start an IV. Another one is a seizure patient. You should start a seizure patient. So a seizure patient's IV, where you find the seizure patient, all right? And then if he has another seizure, you'll be able to then and there give them a medication that stops their seizure. So those are good things to fly by. And when you're doing simulations and maybe in the clinical environment, when the student comes across that, you're seeing them start IVs. They value that. But then they come across a patient who has a severe head injury and is seizing, and now maybe starting an IV on scene doesn't make sense. This is definitely a neurological priority 1 trauma patient who needs to get to the hospital, and now maybe an IV isn't as important as where you can move and get going to the trauma center because of all of the other things that are wrong with the patient. This is at the organized level, you're able to prioritize, you're able to use judgment, and sometimes you'll do the skill and sometimes you won't. Sometimes you'll do it right away, sometimes you will delay the skill. And then the last one is character. And then this has now become part of the student's lifestyle. All right. They are at their pinnacle. They're at the top of the triangle then. This very often, if you're at the character or characterization level, this is something that is kind of associated with you. All right. So people might say, oh yeah, he's as good as Stephen Arns at doing this. He's as good as this. He's when something comes up, it's like, oh, that wouldn't happen because that Holly was there, and that's not Holly's character. It would have went this way. All right. So it is automatic. It's consistent. It's defensible. All of those things when it is part of your character. And so let's talk a little bit more about what are we going to do? What we're going to do is be role models, all right? So most of what we talk about when we're talking about education side of this is short discussions, a little bit of lecture, and a lot of role modeling, all right? So we should realize that if we're talking about, it can be just talking about, but it's also doing, starting an IV. If we don't wear gloves, if we don't do this, if we don't do that, we should also expect that same kind of habit to be formed in our students. So we have to model the behavior. That's a number one way to instruct in the affective domain, is to model the behavior that you want done. And so what else does it mean in the classroom? What do you guys think? When you're talking about the affective and the student's attitude, what else are we as EMS ICs responsible for? So some things are, here we go, discussions, all right? It's a discussion, and this is like an ethics discussion, probably number one. And it is one of those things where you'll talk about, hey, you know what? In the field, sometimes you'll start to see people form bad habits, all right? They are indefensibly bad habits, and that would be things that lead to poor aseptic technique, like taking the cap off from something and letting it possibly dangle where it will touch something else. Getting away from starting or splinting when you're thinking, it's a short ride and won't be too bad. To me, one of the big things is cleaning out wounds. I think if a patient is very stable and they have a dirty wound, we should spend time on scene cleaning that wound. That means 5 to 10 minutes of under a kitchen sink within the right amount of pressure, just as they talk in first aid. All right, clean out those wounds, bandage it up with sterile dressings, and bring them to the hospital. Let's get all that glass off from the patient who's in a multi-car accident and has glass here and there, and getting all that off and cleaning the wounds. When you're running scenarios, maybe throw a few scenarios in there that is just what you might call an affective scenario. Some of that would be maybe having broken equipment and seeing how the student responds to that in a way that doesn't make a big deal out of it. Maybe it is having a student who just complains of a lot of pain. I should say a patient who's playing the student, a lot of pain that doesn't look like a lot of pain, and see if they give them drugs. Maybe it's a patient who usually has drug-seeking behaviors, but today she has a bad laceration, let's say an open fracture. Do they give her the morphine? During your clinical and internship, the preceptors should be doing affective evaluations. So some of that would be just point by point on a daily. And then in your internship, we actually have, full 3-page forms where they're doing affective evaluation. And then for us as instructors, what we do is we do affective evaluations, and that would mean talking about the affective evaluation in the first few weeks of class, and then doing maybe some scenarios and talking again about it. Talking about it, for us, the big conversation comes when you're doing the patient assessment and history taking and talking about all of those little things with verbal and nonverbal clues. And then in about a month in, give them an affective evaluation where you're maybe saying, hey, you're competent in your professionalism, you're competent in your empathy, because we ran the scenario and you showed empathy. You're competent in your, how about this one? You're not competent in your time management because you've been late for class twice. That would give them a non-competent. And then you talk to them and say, at the end of class, you have to be competent in all of these things. And that would include time management. So the affective evaluation that we, and then here on the last slide, we have the 2 reasons to do affective evaluations. We can sum these up pretty quickly. One is we're going to verify affective competence. All right, so at the paramedic level, this is I should say at both, really, at both they are requirements. At the paramedic level, it's something that they're going to come and look at through the COAMPS site visit, but on EMT, for EMT classes, the state comes in and verifies that every student has an affective evaluation. We do this for EMTs just at the end. Paramedics, we do it at every module, and we talk about it a lot at the very beginning of class. I think this year it'll be my challenge to Jeremy to do more talking about affective early, and then do an affective evaluation at the halfway point. Give some change in behavior ideas, and then make sure everybody's competent at the end. And then here, the second reason is a method to change behavior. So when you do see, we have one that's called a behavior form. When we see something like poor attendance, it could be something like inability to talk to patients, inability to stay focused when we're in an adult, the learner-led things. Then we'll give them a thing that says, hey, we need to see a change in behavior. You need to stay focused. This is adult education. You need to act like an adult, stop screwing around, those kind of things. And then make sure that they do that. By the end of the class, they should be competent, and then you'll be able to go back to that top point and verify their competence. That brings us to the end of the to this lecture. So affective evaluations, big things that you need to take away is you need to first, number one way that we teach it is we model it. Number two, all programs have to have affective evaluations. Great chance that that's one of the state questions. All right, it's not just for paramedic, it's for all. And then Affective evaluations are also there to help change behavior, all right? And everybody has to be competent at the end. And I think that's it. I hope you enjoyed it.